با سلام و روز بخیر به همه شما عزیزان. من محمد شکرمیری هستم و امروز افتخار داریم که در کنار خانم دکتر مریم گل محمدی وبینار بعدی خودمون رو به شما معرفی بکنیم. خانم دکتر در رابطه با Brief Introduction to Leber's Hereditary Optic Neuropathy LHON صحبت میکنن. ایشون پست داک ریسرچ فلو از سادن لب UCLA هستن و امروز ساندی اپریل 27 2025 هست که ساعت 2 بعد از ظهر به وقت ایسترن ما این برنامه رو شروع میکنیم. خانم دکتر گل محمدی یکی از جوانترین ریسرچیست های ما هستند که در سال 2022 ایشون فارغ التحصیل شدن از دانشگاه شهید بهشت در ایران و در این مدت چه در دوران دانشجویی و چه در مدت بعد از گریجویشن ایشون در رابطه با ریسرچ خیلی فعال بودن و در بیش از 42 پیپر ایشون فعالیت داشتن، مقاله نوشتن و در بعضی هم نفر اول بودن که واقعا بهتون تبریک میگیم برای فعالیت‌های علمیتون. و بعدم که به آمریکا آمدن و در آمریکا مشغول ریسرچ هستن و انشالله که به زودی هم در رابطه با برنامه‌های رزیدنسی یا موفقیت بیشتری داشته باشن و ما اخبار خوبی رو بشنویم. من از ایشون خواهش کنم که برنامه خودشون رو شروع بکنن و به همه عزیزانم که وارشتن خوش آمد میگیم و اگر سوالی جوابی هستش در آخر ما برنامه رو برای سوال جواب خواهیم داشت. خانم دکتر بفرمایید.
Good afternoon, everyone. First, I would like to mention that even though we are all Persian doctors, I will be presenting in English because it allows for broader accessibility to the global scientific community. My name is Maryam Golmohammai, and today I will be presenting a comprehensive overview of Leber's hereditary optic neuropathy, commonly known as LHON. I'm a postdoc research fellow of Dr. Sadoun, and it's my pleasure today to share this important topic with you. I have the privilege of working with Dr. Sadoun. It's better to say that under the supervision of Dr. Sadoun, who is a pioneer in the field of neuro-ophthalmology and also mitochondrial optic neuropathies. As I told you, today I will be presenting a comprehensive overview of LHON, integrating both classical knowledge and also some of the latest insights that have emerged until today, so far. And let's, okay. LHON, or Leber's hereditary optic neuropathy, is a mitochondrial optic neuropathy where mitochondrial dysfunction leads to vision loss. It primarily affects RGC's retinal ganglion cells, and finally it disrupts the optic nerves. The important thing is that the LHON is not only the inherited optic neuropathy, so we should distinguish it from another optic neuropathy called dominant optic atrophy, DOA, which is associated with nuclear DNA mutation. Both of these disorders, the LHON and DOA, leads to degeneration of the RGC's retinal ganglion cells, but LHON specifically stems from mitochondrial DNA mutations. So I summarized the important feature of LHON in this slide. And let's first look at the epidemiology and genetic background to better understand the scope of the disease. Although LHON is considered a rare disease, it's the most common mitochondrial inherited disease worldwide. And the prevalence estimates vary, but the recent meta-analysis suggested that about 1 in 40,000 people are affected. And in the northeast of England, this is closer to 1 in 25,000. In this disease, the male predominance is the structure feature, is a strong feature, which a male to female ratio ranging from 3:1 as high as 8:1, depending on the mutation type and the population. And the typical age of onset of this disease is 15 years old to 35. But in the next slide, I will tell you about the different type of the disease. There are two types, type 1 and type 2. Type 1, the age of onset is 15 to 35, and the type 2 is 39 and above. So, now that we know how the disease often occurs, so let's explore what causes the LHON at the molecular level. LHON is caused by point mutation in mitochondrial and pass through the maternal line. So there are three primary mutations that are responsible for the majority of cases. The first one is 11778, which is the most prevalent one, and the second one is 3460, which is the worst one because it has the worst prognosis. And the last one is 14484, which is the best one, and because it has the best prognosis. These mutations affect the complex 1 of the mitochondria of the respiratory change, and this mutation leads to reduced ATP production, and also it's accompanied with the excessive production of the reactive oxygen species, and so it causes the retinal ganglion cell loss. Notably, LHON mutations are usually homoplasmic, meaning that almost all mitochondria carries the mutation. But in clinic, we can visit another patients that has heteroplasmic, and their symptoms are milder than the homoplasmic. And in this slide, you can see the inheritance pattern of the disease that are also unique and can sometimes be confusing. So why? Because mitochondrial DNA is inherited exclusively from mother, so only women can pass this disease, the LHON disease, to their children. Though both sons and daughters can be affected. However, because males are more frequently symptomatic, sometimes LHON mimics X-linked or also dominant inheritance. For example, in this figure, you can see panel A shows a true mitochondrial inheritance. Panel B, it's kind of pseudo-dominant pattern, and panel C, you can see a pseudo-X-linked pattern. Okay, and in these slides, as I told you, this affects and blocks, this disease blocks the complex 1 of the mitochondrial respiratory chain, and this leads to reduced production of ATP and increased excessive production of the ROS. And this oxidative stress selectively harms the retinal ganglion cells, and subsequently, the patient lost their optic nerve. And the important question in this disease is that, okay, many all cells in our body have the mitochondria. So why RGCs? And the questions that so far we found is that because they have the longest unmyelinated axonal segments, so this feature makes them particularly energy demanding and vulnerable to mitochondrial dysfunction. And another important thing that we always tell to the patients is that The smoke, and also alcohol intake can further increase the oxidative stress, and so it accelerated the disease onset. It's a schematic view of the LHON mitochondrial DNA mutation that impaired the complex 1, and and you know, it was thought that the problem is about the ATP, the reduced production of ATP, but the problem it wasn't the ATP. The problem was the excessive production of ROS. And so the ROS could affect the RGCs and could lead to legally blindness. And about the clinical manifestations of LHON, clinically LHON presents in two major groups. One of them is the asymptomatic mutation carriers, which are mostly the mothers and the women. There are the asymptomatic carriers and the symptomatic patients. The asymptomatic carriers, although they have no visual impairments or visual complaints, they may still show early microangiopathy and also optic nerve fiber swelling detected by OCT, optic coherence tomography, which is the most important instrument for this disease. And the other one is the symptomatic patients, that for symptomatic individual, the hallmark is a subacute, painless, central vision loss. Typically, it begins in one eye and it affects the other eye in the next weeks. And I want to mention something in this slide that I told you that typically it begins in one eye and then it affects the other eye. We recently did a research on the patients that had the asymmetric onset of the disease. For example, they have one eye affected and then they have the other eye affected, and we saw that the one that has the eye that goes, the second affected eye do worse than the first affected eye, because when we start the treatment for these patients, they worsen their outcomes, means that the later onset of treatment have the better outcome for the patient, which is you know, in contrast to other disease. So it's confusing that it's better to start treatment sooner or wait to start the treatment later. And on the fundus examination of these patients, the LHON triad includes the optic disc fiber swelling and microangiopathy, and also lack of fluorescein leakage. This feature, the lack of fluorescent leakage, distinguish LHON from the other inflammatory optic neuropathies like the optic neuritis, because if the disease is inflammatory, we expect to have the leakage of fluorescent leakage. And importantly, in asymptomatic carriers, fiber swelling and vascular changes can sometimes already be seen. And also I want to mention about the inflammation. We did the research that we want to present it in ARVO 2025 in May. That we saw some pro-inflammatory mechanism in LHON that previously thought that it's not an inflammatory disease, but we have found some pro-inflammatory cytokines such as IL-1, IL-6, and TNF-alpha in the optic nerve head. So if it's a, if the inflammation has a role in this disease, we can
خانم دکتر
yeah.
خانم دکتر ببخشید من اینتراپ میکنم.
بله.
یه لحظه چند لحظه صبر کنید برای اینکه صدای شما اکو میشه در این لحظات و
بله.
ممکنه که گاهی اوقات به اصطلاح پخش نشه. یه چند لحظه استراحت، حدود 10 ثانیه بریک بدین بعد شروع کنین. مرسی.
بله.
خب بفرمایید.
بله. I was telling that previously it was thought that the inflammation is not, it hasn't a role in this disease, but based on our recent article, based on our recent, investigation, we found that some pro-inflammatory cytokines have the role in this disease. And we divide the LHON patients in 4 stages. The asymptomatic, that they are the mutation carriers like the moms and mostly the women. And the other one is the subacute up to 6 months after onset. And the other stage is dynamic, which is from 6 to 12 months, and the chronic one, which is up to 12 months. And typically vision loss worsen quickly over 2 to 3 months, then stabilized into chronic optic atrophy. And this is I summarized the most common feature of LHON. And it is a bilateral symmetrical vision loss, and it causes the profound loss of color vision. Also, it causes central visual field defects, and in the OCT, we can see the temporal pallor. In the fundus images, we can see the temporal pallor of optic discs. And this one. And as we see in this slide, we can see fundus images of a symptomatic LHON carrier, which is obvious. It has the macroangiopathy at the level of optic nerve head. And also in the OCT, we can see the swelling, which is the feature of asymptomatic LHON carrier. And the visual field defects are typically central and centrocecal scotomas in this disease, but it's in the early stages. And also early psychophysical abnormalities can include color vision loss, which is particularly red and green, and also decreased contrast sensitivity. As you can see in this figure, it starts with a central scotomas, and then it progressed to legally blindness. And this figure also showed the central scotomas, and then from A to F, it progressed to legally blindness. And about the ophthalmoscopy findings, we have 3 stages. In first stage, asymptomatic stage, as I told you, it's a fiber swelling and some microangiopathies. As you can see, I make the arrows around the places that we can see the microangiopathies. And at the first stage of the disease, we see the RGC swelling, which can be due to oxoplasmic stasis or the RGCs are struggling to maintain their energy-dependent cytoskeletal transport. As you can see in this figure, is the nerve swelling, and also microangiopathy in asymptomatic LHON carrier. It's good to mention that recently we did a machine learning study to see whether the vasculature features are different in LHN affected patients and normal individuals without any underlying diseases. And we found that their vascular features are totally different with the normal individuals, and and we saw that we have the loss of the arteries in these patients. And a pre-symptomatic stage, that this stage is before we saw the patients, maybe it's 2 months before the onset of the symptoms. And also as the asymptomatic carriers, we have the fiber swelling, optic disc hyperemia, and this progress to clinical symptoms. And as you can see, I just draw these arrows to show you the loss of the arteries there. And in the symptomatic stage, that we have the vision loss. And the optic coherence tomography is the most important, tomography for our LHM patients. And the OCT imaging is crucial in LHN, and in early OCTs, we can see the prepapillary RNFL retinal nerve fiber layer thickening in temporal and inferior sectors. At first stage, as I've told you, we have the thickening, not thinning because of the swelling, but at the later stage, ganglion cell layer thinning, we see the thinning of a ganglion cell layer at the macula. And this is the OCT and also visual field of a patient. At the most left side of the slide is 7 weeks before the onset of the disease, that we can see the swelling, a higher rate of swelling, and also a central scotoma. And when the disease progress and to the onset, the obvious symptoms, the visual field is it's worsen, and also we will have the RNFL thinning. And about the predictive risk factors and atypical features, although LHN often leads to severe vision loss, certain factors predict a better outcomes. The favorable factors for better final visual prognosis, first one is the childhood onset, and the other one is 14484 mutation, and the other one is larger optic disc area. And a visual recovery typically occur between 12 to 24 months if it happened at all. And some LHM patients present atypically. For example, one of them is childhood onset. The typical age of onset is from 15 to 35. But in childhood onset, it's the earlier onset, sometimes unilateral. And this type, it has the better prognosis. And the late onset LHN is after age 50, often associated with the heavy smoking, smoke, and alcohol intake. And this is the thing that we all advise the patients, typically the carrier one, that we tell them that you should avoid from the heavy alcohol, drinking. Also, you should be avoid from smoke. For example, the wildfire smoking, and also a prolonged use of antibiotics. And as I mentioned before, we can think of LHN as two types. Type 1, which is the classical form, and it's the genetic dominant, and it has the earlier onset and it's severe. And the type 2, which is the genetic plus environmental factors such as alcohol, smoke, and antibiotic use for a prolonged time, and it has the later onset and it has possible recovery. This is a diagram that showed the type 1 and type versus type 2, the onset, and also the number of LHN individuals higher in type 1 versus type 2. This is the comparison between type 1 and type 2, which I told you before. And the last one that I want to mention is the histological studies in this disease that showed a profound loss of RGC, retinal ganglion cells, and also severe thinning of retinal nerve fiber layer. And the interesting thing is in this disease is the preservation of photoreceptors and outer retina. So this selective susceptibility explains why LHN cases central blindness, they have the central blindness, but they spares the peripheral retina. This is a histological study in a normal, a control individual, and this is the LHN patient, which shows the profound loss of RGCs in the LHN patients. And also in this slide, we can see from the most left images is the mild LHN patient, that the brown color means that they have the RGC, the axonal segments, and the first place that they miss their nerve is the temporal side. This is the mild LHN patient. The middle one is the moderate one, and the other one is the severe LHN patient. And the important thing is that the smallest fiber are so susceptible to the loss. And at the end, for this disease, the only treatment is the idebenone, which is the coenzyme Q10 analog. It's the FDA-approved drug for the LHN, but it's the FDA-approved drug in Europe, but it's not the FDA. It's not approved in the US. So it's the only drug that they should take with the vitamin C, and it helps to support the mitochondrial function and also reduce the oxidative stress. And thank you for your attention. If I would be happy to answer any question.
Thank you very much, Dr. Golmohammadi, for a very nice and comprehensive description and explanation of this disease. Thank you very much. You did a great job. And if anybody has any question, please raise your hand or just unmute yourself and ask your question. And meanwhile, I can ask the first question. As you mentioned, that was very confusing for most of the physicians to know that the later treatment would have a better outcome for the second eye. But it was not quite clear for me that the treatment on the very first eye would be beneficial to start treatment later on, or on the second one to start.
On the second one, But when we started idobenone, they take it orally, so we can avoid, you know, the expose of the second eye to the drug. So, you know, it said the research are in progress about this, and we just did it, you know, in a small sample, and we saw that if idobenone is started, for example, when the patient, the onset of the patient is less than 6 months, and if we start the idobenone when the disease onset is less than 6 months, the results are not good. So it's better to wait for the 6 months, and then we can start the idobenone. It's but you know, when they come to clinic, they all have the disease and it's over 6 months. So we start the idobenone.
Thank you very much. If anybody else has any question, please ask the question. And usually we say if there are no questions after a talk, so it means that you did a great job and explained the topic very nicely. So there is no question. But we will give 1 or 2 more minutes, and then if not, so we can thank you for your good explanation and webinar
Thank you so much.
of this very complicated disease.
Yes.
Mitochondrial diseases are not easy.
Yes, and the good point is that when we start the idobenone for them, after the result is not too soon. We should wait for more than 9 months after we start the idobenone, and after 9 months, for example, a patient with legal blindness, they can see. They can see, they can read and watch, you know, they can do their regular activities.
Very good. That was also a thank you from one of the audience. He thanked you for a good presentation. So yes.
Thank you.
Okay. Yeah, if there are no more questions, so we would like to thank you for your presentation and great job, and good luck with your research career and also future residency.
Thank you so much.
Thank you very much. Thank you.
Thank you.
Bye-bye.
Goodbye.
Bye. Let me stop the recording.